All right, I'm going to go ahead and start. Another casualty of switching texts. He combined two chapters, 5 and 6, into one, chapter 4. Not sure how that happens, but it is what it is. Yeah. You guys got those memorized, right? You barely read them. They're so small. But it's out of the text. And you have them in your list at the beginning of the modules. So. Basically, this is going to be talking about a patient assessment after birth. So how about a little video? They're all jumping around. He's going. This has to be photoshopped or something. Because I can't believe you could do that. Don't try that at home, okay? All right, well, let's go back and touch on a couple of things talking about apnea. Remember, whenever we have a cessation of breathing, in a neonate we go with 20 seconds. And if that, or any period long enough for hypotension, bradycardia, and cyanosis to develop. Do you guys have this or no? No. So I guess I got to send these to you. Just listen then. It's on. Now, this is different than periodic breathing. Those of you who have children know when you watch them breathe, they breathe and then they stop, and then they breathe and then they stop. That's kind of normal. That's part of the brain, especially in prematurity. It's part of the brain learning it's what it's supposed to be end up doing. This is basically when you have a premature child, less than 37 weeks, and you end up having these apnea leading to bradycardia or leading to cyanosis. It's basically the neurological system isn't fully developed yet. So again, any baby born prematurely, the neurologic function is going to be suppressed, or it's going to be a little bit behind the time. Okay. The more immature, the more premature, the bigger the incidence, the bigger the problem associated with it. We treat it, interestingly, with methylxanthines, and if you remember methylxanthines, you've heard them before. They were something called those side door bronchodilators, right? But specifically what we end up treating them with is caffeine. And caffeine is being a stimulant, and it causes them to have less apneic periods. We also can use CPAP, and we'll talk what CPAP is and how it's applied next time. Two types of apnea, primary and secondary, novelly named. Okay. Primary apnea is the one that responds. It's usually a response to hypoxemia or hypoxia, and just a small bit of stimulation relieves it. This is why we go ahead and rub the sole of their feet or rub their back. Okay. Secondary apnea is associated not so much with a response to stimulation, but basically they have gasping or very poor ventilatory efforts, and this is one that you got to ventilate the kid on. Now the problem is when they come out and they're apneic, you don't know if they had a primary apnea episode in utero, and now it's manifesting itself as a secondary. So we need to be aggressive and assume that it's secondary until proven otherwise. If they don't respond to stimulation, we're going to go ahead and ventilate them. On the left-hand side, you can see primary apnea. There's a drop in heart rate with the apneic period. Stimulation brings it back up. With secondary apnea, that does not happen. Okay, so primary versus secondary. Should have an idea between the two. All right, let's take a look about the neonatal patient. First of all, talking about gestational age. Look at the little GIF. We're going to do this within the first 12 hours after birth. Weight is a very, very poor estimate of age or development because they don't all grow at the same rate in utero. My son actually was, I think, 5 pounds 5 ounces when he was born, very, very small term baby. But there perhaps was some problem in utero where we think at least the placenta detached, reattached. And in the process, there was some growth development problems there. 2 scales. I want you to at least know the name of the first one, Dubowitz. It's not used anymore, but it's the one upon which the Ballard was modified to be able to work. We're going to go ahead and use this to predict their gestational age. Okay. And this is what it looks like. I don't expect you to memorize it. It's in your text if you want to look at it. But it's basically looking at different reactions. So when you hold their arm out, how does it respond back? Does it just stay there, or does it become where it comes back towards the center of the body? How is their posture? Babies, as you know, have that little, almost like a frog positioning, and if they're limp and lying there, that's obviously not a sign as being as fully developed. So it's looking at various things as far as their body's response, and looking at things that we'll talk about in a second, things like lanugo, things like the presence of breast tissue, things like their eyes open or are still fused shut. And this is important because there's various morbidities that can exist as you go towards that left side where it's more and more preterm. And we'll get through these when we talk about jaundice today, but various congenital anomalies, various diseases like RDS, as we go. We're going to call small for gestational age, less than 10%, and anyone who's greater than the 90th percentile being considered large for gestational age. That's what those 2 terms mean, SGA and LGA. So based upon their gestational age, if they're bigger than you would expect them to be, that's large for gestational age. Vital signs are basically based upon their gestational age. Here they describe them or place them as, according to birth weight. For right now, I'm not concerned that you have a specific idea on what the blood pressure would be for a 4-year-old. Okay. For right now, what I'm really concerned with is just recognizing that babies are born hypotensive compared to what we would assume, and that they're going to, as they develop, their blood pressure will become larger. This is a rough rule. I don't ask you a question on this, but basically the gestational age in weeks plus 5 is what their mean blood pressure would end up being. Very rough estimate. Some of the terminology and things that I want you to be aware of. First of them is called vernix caseosa. I think I said that right. Caseosa. It's basically a cream cheese-like material that covers the fetus. It just sounds wrong. But it is kind of just this cheesy-looking stuff that remains. It appears at about 20 to 24 weeks, so and it remains thick until about 36. So if we see very minimal amount of this, we know that gestational age is going to be a little bit earlier in nature. Lanugo is another one. Lanugo is a fine downy hair that covers the fetal body. We start seeing it at about 26 weeks, so born before then, we're not going to see this present. And if it's not there and the baby's older, again, eventually it's going to thin and disappear by about the 32nd week of gestation. Vernix lanugo. Babies born prior to 26 weeks often will have extremely thin gelatinous skin that you can literally see the blood vessels through. This becomes a problem, as I might have mentioned previously, about placing sensors and electrodes and all that kind of stuff. We try to minimize that as much as possible because removing them can lead to some damage to the tissue. Jaundice is a yellow-orange skin color that is a result of hyperbilirubinemia, a high bilirubin level. Okay. Basically, this is a result of the breakdown of erythrocytes. They're normally eliminated through the GI tract or the kidneys, and in cases where the bilirubin is greater than 4 to 6 milligrams per deciliter, that's where we'll end up seeing jaundice. Premature babies are notorious for having jaundice. Their liver isn't fully developed yet, and the processing of erythrocytes is a little bit delayed. So the liver can't handle the load, and the baby becomes a little bit yellow-oranges. Cute, but he's a little bit colored. So the problem with this is if the levels get high enough and are not treated, it can lead to something called kernicterus, which is basically an encephalopathy that develops secondary to the high bilirubin. Now, what did I just say? It means the liver can't clear the bilirubin, and you end up having basically brain damage that can be encountered secondary to it. So this is not something that should be taken lightly by any stretch. Way we treat it typically is just simply putting them under what we call Billy lights. Novel name. It's basically phototherapy lights, UV lights, and just let them go ahead and bake in the sun for a few days, and the bilirubin will be reduced in the process. If it's severe enough, we can do what we call exchange transfusions, and that's getting a little bit involved. Basically, we go ahead and usually they're catheterized through their umbilical artery, so we have access to the vascular system. But literally, what we end up doing is taking 2-3 milliliters out, wasting it, putting 2 to 3 milliliters of fresh blood back in, and we do this until we can get a large volume of blood that's been basically transfused and recycled, with the hope that obviously the bilirubin will come down in that process. Respiratory rate you should know is about 40 to 60 breaths per minute. Again, there do have these rhythmic periodic breathing, or you do have these interruptions in the rhythm with periodic breathing, where periodic apneas, but they're not significant. There is a scoring system where APGAR is used at birth, and a high number is good. There's something called the Silverman-Anderson score, which is basically an indication of respiratory distress. So this is a little bit opposite. On this one, a low number is good. Okay. The higher the number, the more distressed the child is. And then what we're looking at are things like nasal flaring, or the LA nasal, little muscles that surround your nostrils that they flare. It's really interesting when you see a child who's intubated who is flaring their nostrils, and it's like, dude, it's not going to do anything. There's no airflow. Grunting and retraction. So this is the Silverman score. It's out of your text. You can end up seeing it. But you can look at the upper chest, the lower chest, xiphoid retractions, dilations, and grunting, and you can be able to see that a lower score, a score of 0, is what is desired. A score of 2 is something that we definitely do not want. Okay.
Just that.
I want you to know that it's called the Silverman-Anderson score. I want you to know that it's measuring respiratory distress, and a low number is good. I wouldn't give you a description and ask you to do that. I will do that for the APGAR score, but I won't for this one. Cool? Looking at some physical examination things, looking at the chest, a couple of deformities of the sternum that you should be aware of, and I got a picture of them here. One is called pectus carinatum, or pigeon breast. The other one is called pectus excavatum, or funnel chest. One is where the sternum abnormally protrudes outward. One is where the sternum abnormally protrudes inward. Obviously, that can lead to some restrictive disorders depending upon the extent to which the the sternum is displaced. It can also cause a point of maximal cardiac impulse to change, the PMI. I think Mary probably somebody talked about that, didn't they? Jeannie or Ray? No? I talked about it? Well, you don't listen to me anyway, so why not? Just as an aside, neonates often will have a point of maximal impulse that is just to the left sternal border, as opposed to being much more shifted towards the left as you would find it in us. And that's because the right ventricle of a neonate is often a little bit larger, because that's the ventricle that's been doing all the work in utero. We have a shift of the point of maximal impulse. That means that perhaps something untoward has gone on where the heart has shifted, and one of the things where that can occur with that is a pneumothorax. One advantage of a neonate is we can actually use what is called transillumination, where we take a bright light, shine it through, and if there's a pneumothorax there, it'll appear characteristic. The light itself will actually have a halo around it, you'll end up seeing. This is pectus carinatum. This is pectus excavatum. Okay. For the most part, benign, but again, they can lead to some respiratory impairment if they're significant. And there are some gross pictures I have where I apologize, but it's the only way to get it across. Well, we're going to also assess things that you would expect to have: heart rate, cardiac sounds, looking for murmurs or other abnormal valvular functions. Checking pulses, both peripherally and centrally in all locations. We'll find measuring blood pressure and pulse oximetry. And again, we want to measure that pre and post ductal to identify if there's any kind of intracardiac shunts going on. We'll actually find one of the diseases that we'll talk about, one of the cardiac defects, coarctation of the aorta. We actually have a blood pressure peripherally on the left that's different than the blood pressure on the right. So there's a good reason to monitor in both extremities. Abdomen, we're going to look as far as the shape or the contour of it. There's one specific disease state we'll come back to, is congenital diaphragmatic hernia, where it ends up having a scaphoid abdomen. Scaphoid meaning looking like a boat, dipped out, scooped out. Can also do auscultation and palpitation, more than just the stomach, looking at the intestinal area, looking at the cord. And then there's two disease states that I'll make mention of. And again, these are a little bit gross. The first one is
gastroschisis.
The other one is
omphalocele.
I can never say them myself, so I have a little sound thing that is there. These are basically both abdominal disorders where the abdominal cavity is presented outside of the body. So baby is born and the abdominal wall never fully closed, so the intestines are born outside. This is gastroschisis. Notice that the bowel is basically fully exposed. This is omphalocele, and it's basically where it's enclosed in a membranous sac. Obviously, this is something that's going to need to be surgically repaired, and the abdominal contents placed back inside. This one, at least, the omphalocele is a little bit better if you want to consider it that way, because at least it's not as prone to infection as it is with gastroschisis. Also looking at other things like the shape of the head, whether or not there's edema, whether the face has been scarred during the birthing process, looking at the shape of their ears, and then continuing on with the head and neck, looking at their oral cavity. One I would like you to at least be aware of is that we can have bear in mind, pretty much any part of your body can be abnormal, big or small. There actually is a text that basically summarizes every disease state that, as far as how they present. One I would like you to know is a child born with an abnormally large tongue. The tongue is actually inserted further back in the mouth than it would normally be. And they also have what is called micronadia. Now, micronadia means that the lower jaw is smaller in size. So it doesn't. It's more than just having an overbite. It's one where you end up having the jaw drastically displaced back. And this is a photo I picked up on Google that shows the jaw being smaller in size. Problem with this is I got a big tongue and a small jaw. You're talking about airway compromise. In a lot of cases, they may need to have even an oral airway, which is difficult to do on somebody who has any kind of low consciousness, but certainly their airway has to be paid attention to because they can go and become an obstructive element, especially during times feeding. Okay?
Can you go back one slide, please? We don't have that.
Micronadia. And it's called Pierre-Robin syndrome. It's just a cool name. I mean, come on. Pierre-Robin. Micronadia. Now, can you have macronadia? Absolutely. Can I have microglossal, where the tongue is small? Absolutely. The good Lord can make a mess of us in a lot of different ways, so sometimes you just gotta deal with the hand you're dealt. Oral cavity also, a lot of times, especially with some of the trisomy 18, you have a very small oral opening. Some of them, things like Down syndrome, you may have a very large opening. Taking a look at this, the musculoskeletal system, the spine and extremities, looking at any kind of morphologic changes, webbing of the fingers by the, as an example, abnormal number of digits, 6 fingers on a hand. For those of you Princess Bride fans. Abnormal positioning of joints where they don't bend in a normal mechanism. And you can have some spinal defects. This is basically just an open spinal defect. This is the myelomeniingocele I think Mary talked about the very first day that we see with spina bifida, where the spine actually protrudes, or the spinal column actually protrudes out through a defect in the vertebrae. Evaluating their cry, the strength of it, as well as any kind of other abnormal sounds we may hear. And then how they're responding neurologically to their environment. Are they moving? And there's a couple of neonatal reflexes that I want you to know, because you'll see these on the Moro reflex comes back time and time again. People always say, what is the Moro reflex? Let me go back to rooting. Rooting reflex is where the child will turn their head towards wherever their cheek feels. And it's basically not only will they turn their head that way, they'll begin sucking it. The mechanism by which breastfeeding is a reflective mechanism. The grasp reflex, I know you've all done this. You have a little baby, you put your finger in their hand and they grasp it. It's a natural, it's called a plantar reflex. It's a natural mechanism. The Moro reflex is the reflex that you end up having when you take a child and you lift them up a little bit and let their head fall back, their arms and legs kick out, and eventually come back to center. That's a Moro reflex. Again, it's a natural reflex that you end up seeing. Sure. You take a baby and you lift them up so their head just comes up and falls back and their arms and legs go outward. You know what I'm talking about. Yeah, it's different than the startle, but it's close to it. Yeah, the startle reflex is basically the same exact thing, but the Moro reflex is more along the lines of their head isn't as supported as it was previously.
So you're looking for them to actually retract in, or?
No, I'm just looking for that to be there. And that's just, I don't know why it's called the Morrow. Maybe somebody named Morrow first described it. And that's a bad picture of the Morrow reflex. This slide, what I want you to know is that babies born prematurely, babies born, if you're looking at newborns, their lab work is a little bit different. So when we compare it to adult, we're going to get freaked out. So you need to bear in mind a couple things. First of all, they're often what we would consider to be polycythemic in the first few days. This is to be expected. It's not bad. It's just it's got a lot of hemoglobin on board. And eventually, it'll go ahead and if the liver's functioning fine, go ahead and destroy them through the spleen and liver. Their white count is way higher than we would expect to see in an adult. We're going to consider, I think I go to the next slide, yeah. And the last one is their platelets are a whole lot higher also. So we're going to look at something where the white count gets above 25,000 instead of 10,000. So it's a whole lot different. And the platelets are basically when they get below 150, where it's pretty much a normal one in the adult. But when they get that low, those are usually signs of infection. And there can be the hemoglobin, not only the level is elevated, but we have to, especially in patients that are our age, immunized, need to be aware of that. When we talked previously, I think, about hypoglycemia. Pediatric patients, I'm just going to breeze through this. This is kind of general information. But there's basically, when you have a new patient coming into the ER, some of the things you want to address. The chief complaint being the primary one. Any history of present illness, past medical history, family history, and social. So the chief complaint is basically, why are you here? And multiple things can end up getting us an idea. Looking at their past medical history as far as their history of prematurity, kids that are born premature are going to have more problems further on in life. What their birth weight was, were they small for gestational age or large for gestational age? Assessing their breathing to assess whether or not they need any oxygen or assisted ventilation. Assessing whether or not they've had prior ER visits, prior surgeries, and what's their immunization history. So these are all things that are going to be a little bit of a background information. Looking at the family history, if it's not the biological parents that are with, is there anything significant about their biological parenting? Are there, any diseases that are abnormal in siblings or other close relatives? Looking at things like especially school-age children, are they missing school? The degree to which they have social participation, all common sense stuff. Looking at symptoms, not only pulmonary but also non-pulmonary examination. Somebody in respiratory stress is going to have some very characteristic, and especially when you're talking about a baby, it's difficult sometimes to pick up on the fact that there's something wrong because they can't communicate with you. You got a 6-month-old who's not going to be able to talk and tell you what's wrong, where a 4 or 5-year-old might be a little bit a better one. A couple of things that I want, and I'll show you a video on. Head bobbing is very common in these children who are in respiratory distress. Just simply having a child who's fussy or doesn't recognize the parents. That's usually a very poor indicator. Maybe it's a very good indicator of a very poor situation, is what I was trying to say. Again, a child who's not crying is typically an issue. We talked about chest abnormalities and abdominal paradox. Again, normally when you inhale, your abdomen goes outward. If it goes inward while the chest goes outward, that's what we call paradoxical breathing, seesaw breathing, and it's a very poor sign. Let me get this to work. That's head bobbing. That's a sign of an infant in pretty significant respiratory distress. Here's another one. Okay. Yeah, poor little guy. Then going through your other assessment, looking at things like using your hands to assess tactile fremitus, using your hands to determine position of the trachea. Percussion usually is better on bigger children than it is on neonates, small infants. The problem with them is that there's a lot of transmitted sound that you end up having. And then there's your various lung sounds that you end up having. Grunting, again, is a mechanism that is normally, that's not normal, that is done physiologically to try and cause some back pressure. So when you're seeing that happen, grunting, that's a sign that they're in respiratory distress, and they're trying to basically keep their alveoli inflated by applying some back pressure. Stridor, you know what that is? Stertor. Now, I did not know what this is, so I had to go do a little bit of research on this. And the only example of stertor I could find, well, you'll see in a second. But you know about wheezing and other kinds of stuff that is going on. This is stertor. Chihuahua. That's all I could find. Do you hear it though? It's like a little snore that is there, and it's kind of a wet sound, and it's a sign of some upper airway obstruction. Non-pulmonary, looking at things like growth delay and developmental delay, looking at neurological abnormalities and muscle weakness. EENT, ear, eye, nose, and throat. Allergic disorders, there's a couple of them that I want to show you. One is called allergic shiners, and one is called Morgan-Denny lines. If I saw this child come into the ER, I'd say, oh, we have some little allergies going on here from something. And it's probably going to might often present as what your asthmatics present as. So, yeah.
This monophonic and polyphonic, is that just like unilateral?
No, monophonic means that they're one tone. Polyphonic sounds like a musical orchestra. Polyphonic, in other words, there's multiple pitches that are there, both deep and high. And if you're hearing on an asthmatic wheezing that is very musical, where it's all over the scale, that means that there's multiple size airways that are being impacted, where monophonic usually is just more peripheral and not as diffuse, probably. And these are Morgan-Denny lines. Again, both signs of allergic. You just look sad. Get me out of here, Mom. Heart sounds, you'll end up having, usually you don't have murmurs or galps, but in a lot of the cardiac defects you will have murmurs. We do have a more prominent second heart sound. The dub is a little more prominent in pediatric patients. Looking for things like abdominal distension, and as far as extremities, looking at digital clubbing. And I think I don't know if Mary did or if Jeannie did, talked about digital clubbing being present. Again, it doesn't hurt, it just looks funky. And some of them, the clubbing is so pronounced that they're almost like grapes, bulbs that are there. Not usually. Usually the digital clubbing occurs secondary to chronic hypoxemia. So we'll see it on our cystics. We'll see it on some other long-term pulmonary diseases where you end up having profound hypoxemia long-term. You don't have this, so skip it, and we're going to leave it there. This is called disaster. Questions?
We got one.